Thank you and good morning. If you're joining us on the Health Watch meeting, the steering group meeting, this Tuesday morning, you're very welcome. Thank you for joining us. All the members of the Health Watch steering group, I should say, are volunteers, and they're all here to discuss the issues involving the NHS in the area. And if you want to find out more about Health Watch Coventry, you're very welcome to do so on our website, which is pretty easy to find. Just put Health Watch Coventry into your search engine and you'll find it very easily. So let us move on to the first part of our meeting, where we invite from our members any declarations of interests. No, I think we're all clear on that. The minutes of our last meeting, held on the 1st of June, have been circulated. Everybody happy that they are accurate? If not, please say so. And are there any matters arising that are not on today's agenda? No, good. Thank you very much.
And all actions have been completed.
Thank you. Yeah. So we move on to items for discussion today, starting with the values of Health Watch and an update on that from our Chief Operating Officer, Ruth Light.
Okay, so I have circulated a paper which is called Health Watch Coventry Values Refresh. So Health Watch Coventry's values were set some years ago, and Health Watch England has been doing work on the values. What we're going to try and do now is actually share some slides. So Owen's going to do that for us so we can bring up what I've written for everybody to see. So here we go. So what I've done is I've looked at what Health Watch England have come out with recently. So Health Watch England have been doing a big piece of work looking at the Health Watch brand and Health Watch kind of descriptors and how Health Watch communicates. So as you may recall, Health Watch England has the ownership of the Health Watch brand, and they license it out to the organisations that run local Health Watch. So they had come out with a paper giving their beliefs and values. So I looked at that and looked at our slightly longer list of values that we had, and I've come up with this as a proposed new list of values. So I liked the way that they'd formatted it, and I thought that's something when you're putting information out to the public about who you are and what you stand for would be a useful way of going around it, rather than having your sort of standard number list in a document. And I like the fact that we could try and get it on a page, really. So those are some of the things that I was trying to achieve. So I've drawn from what we had, but kind of updated them. So this is here for you to consider and hopefully approve as well. So our key sort of highlight points are about independence, inclusive, listening, constructive, trustworthy, and open and accountable. So obviously the wording is slightly different from Health Watch England because our role is different from Health Watch England. What does everybody think?
Any comments or observations from members of our group? Please do raise your hand and let us know what you think if you'd like to make an observation. Everybody's happy about what they've read.
Okay. Oh, do you want to take the slide down and then we'll get everybody back on the screen and we can just check that everybody's happy. So is everybody happy to agree those as the updated values that we promote then? Excellent.
In agreement on that.
Okay.
Thank you. So we now move on to amendments then to the Health Watch Coventry governance, our decision making, our involvement policy.
It's a bit of a mouthful, isn't it? So that's one of the things that I'm hoping to sort out in this update. A parallel piece of work that Health Watch England do is provide guidance to local Health Watch, and the decision-making policy is a policy that every Health Watch must have. It's written into the legislation that creates Health Watch, that we need to publish a decision-making policy. So our current longer title document is published and it's on our website. And a lot of the content of that document is still very much relevant to how we operate and how decisions are taken within Healthwatch Coventry. However, there is always opportunity to improve and to make things clearer, and to think about also this is a public document, so to try and make it a bit easier for people to understand. So I have redrafted the documents, but at the moment I haven't sent you the entire document. I've pulled out some key elements which I want you to have a think about and consider, because they're the sort of significant changes really. So my first proposal is that we've reformat the document. So in the new version, it'll be in sections. Because we're a hosted Healthwatch rather than an independent organisation, our decision making and our governance is a little bit more complicated than if we were a standalone organisation. So there will still need to be a section explaining the role of the steering group, which will be more like steering group terms of reference, I would say, in the new document. But one of the elements that I think has become outdated in our kind of approach is the concept of membership. So this kind of came from a long time ago. So from the body that was before Healthwatch, which was the Local Involvement Network, which was a kind of membership based body. And then we kind of carried membership as a concept into Healthwatch. But what is sort of clear to us now really in terms of our interactions with people in Coventry is that asking people to be a member of Healthwatch isn't something that's that appealing really. So we tend to try and get people to sign up to being on our mailing list, or we're also trying to join our network as well as a kind of tag to get people. So we want to have a database, a mailing list of local people and people who have a vested interest in Healthwatch, but membership is not really the kind of terminology, and it also perhaps denotes something that doesn't exist really in terms of the decision-making structure within Healthwatch. So that's one of the proposals for change. So I've proposed some new wording. And the other thing which was associated with the membership that we had in our document was that we defined it very clearly in terms of geography and who was eligible to be a member of Healthwatch. But what I'm now suggesting is that we adopt the wording that Healthwatch England has within its guidance, which is a little bit more generic, which is about saying that people can be on your mailing list, involved in Healthwatch if they've got a vested interest within Coventry, and that covers a number of different angles. So people might live here, people might work here, people might study here, people might care for somebody here, or there might be some other connectivity, which is a strong connectivity with Coventry. So long as there is that element, then that would be why you'd be associated with Healthwatch Coventry rather than another Healthwatch, if you see what I mean, because we have neighbouring Healthwatches. So if you live in Birmingham but you work in Coventry, you have got a vested interest in Coventry as well as Birmingham, haven't you? So
good. Ed, do you want to raise an issue?
Yeah, I like most of the proposed changes. I just had a question about page 3, the decision-making tool, and point 6 on it, which refers to, is this the right point in time to make an impact? And it's weighted 3 on the score. Just because the NHS and health and social care is permanently being reorganised and changed. Before this ICS, we had the CCG merger. My only concern with it is we might indefinitely postpone doing something because it might never seem like the right time to intervene. If commissioners are arguing, well, there's this reorganisation down the road, we might end up doing nothing. Yeah.
So I think it's about what we take on that, isn't there? So our lowest weighting is 1, so it's a mid weighting. So I was going to come on to this scoring sheet. So this is the work prioritisation tool, which we have had since Healthwatch Coventry sort of came into being. We were one of the first health watches to develop something like this. So this is to aid your decision making when about the issues and the experiences of local people, and what you would turn into a piece of work. So put some time and resource into researching or taking forward in some way. So I think there is a kind of timing element to stuff, but yes, we would need to be mindful that we didn't allow that to distract us from something which was really important to local people, or where there was a kind of significant impact perhaps for less heard communities. So I haven't changed the weighting as it was within the score sheet for that. I mean, there is an argument for not having the weightings at all, apart from maybe inequalities weighting, so that would simplify it. So what I've tried to do here is in this is I've taken one column out. So we had two evidence columns previously. So I've suggest that we just have one because it's trying to make it workable really in terms of actually doing this for topics that come up. So I mean, the timing thing would maybe come in with like, so if a service has it did come up with regards to this commissioning cycle. So I think it came up with patient transport once, for example. So if the service has just been recommissioned, actually the point in time to have the most influence was before it was commissioned. So it's to be aware in that way, isn't it? So so if you're weighing that up against another topic area which was coming up to its recommissioning point, that's where you might factor it in, if you see what I mean, because we have to prioritise, don't we? But yes, the NHS has always been reorganised, and there's always something under change, and fundamentally it is about people's experiences. So maybe you would have arranged the work in a different way to have a different angle on it, so that you were helping a new provider or something. What do other people think?
Thank you for that. Thank you for the question, Ed. Any further questions or observations for Ruth on this? Anything further from you on this, Ruth?
Yes. So that's what I've proposed really at the moment, is around revising the concept of membership and then refreshing the decision-making checklist. So as I say, I've tried to make it a bit simpler. So in the Healthwatch England guidance, they have got these 4 points really as the kind of things that Healthwatch need to hang their decision making off. So ours is a bit more sophisticated than this, I guess you could say. So we've got the how the issues fit with our organisational role and responsibilities. Is it within our statutory remit? So that kind of plays into it's like, are we the right people to be doing this, or is this actually something that some other organisations should be doing? It's like, we're not here as a Healthwatch to sweep up work which actually is the function of other parts of the system, aren't we? We're there to do our particular function. Issues that matter to local people. So in our checklist, we've got check and balance on this, because I guess what we need to consider in Healthwatch is you can't always go for the thing that is the volume issue, because there are some services which are used much more by people. So dare I mention GP services? Please don't comment on them now. We'll probably come to them later. But it's like pretty much everybody uses GP services, but a very specialist service for people who have a particular condition will be used by a lot fewer people. But that doesn't mean to say that their views and experiences aren't valid if something is not right within that service. And also then thinking about our diverse and vibrant population, there might be people who are actually excluded from using services as well. And then it's about, also from a Healthwatch point, it's about change that can be brought about. So I think we need to come back to this topic at some point as a steering group, because this links into the kind of theory of change and how you get outcomes as a health watch, because it's frustrating for everybody. It's frustrating for steering group members, it's frustrating for staff, it's frustrating for people who have given their views to us if we aren't able to demonstrate that change has happened as a result of it. And it's hard, and there's lots of reasons why it's difficult or time consuming to bring change about, but that's an area for consideration. And then another one about, does it need to come from Healthwatch? So I think we've got the Healthwatch England framework covered, and then we've got some more basically. So, and we've picked up the kind of, we'd already picked up the equalities agenda, so I've just increased the weighting on that. Is all that I propose. So is everybody happy with that as sort of key changes that I can make in the document? I will be circulating the document to you as well. But I've got a little bit more work to do on it. And then there is an easy read. So with pictures that Healthwatch England have produced, which I think we can adapt at least for the first part, the key decision-making element of our document, which will make it easier to convey to people.
Easy reads are always helpful. Any further thoughts on that, please? No. Okay, thank you very much. We move on then, if we may. You're happy with that, Ruth? Yeah, good, thank you. Let's move on then, excuse me, to the activity of Healthwatch, and the paper has been circulated detailing recent activity, Ruth.
Yes, so this is our usual paper where we kind of record and map activity that's taken place against the work priorities that you've set as a steering group, and then also include other areas of Healthwatch activity, for example, the information helpline that we run for the public, and other things which are a good practice in the running of a Healthwatch, such as collaboration and our linkages through the Healthwatch network. So what have we been working on then? So we completed the mystery shopping exercise of phoning GP practices to see what the experience was like of using the phone systems and how long it took to get through. So we have a report which is pretty much nearly ready to be published now. So I've circulated that around the group before. So people were happy with the report. It was your view that we shouldn't name individual GP practices within the report, but should obviously flag up GP practices where there was an issue of concern. But we'll also see what we can do in terms of actually communicating with GP practices. There's no easy mechanism for doing that at the moment that we can tap into. So it would actually be trying to contact every single GP practice. So we'll see what we can do. So that should be published later this week, and it will be sent to the CCG, and we wanted them to send it to the PCN leads as well. Scrutiny Board 5 of the City Council Health Scrutiny have got an interest in it because they had a recent meeting where they called the CCG in to ask about access to GP appointments. So our work doesn't look at actual access to appointments. It's the front door stuff. So what's also been happening about GPs is that through our kind of increased social media engagement and reach, we've reached some community groups in an area of Coventry, which has led to a significant amount of negative patient feedback about a GP practice. So I've done some quite significant work related to this, really. So I've pulled together anonymised feedback from all of these people, and I've shared it with the CQC lead inspector for that GP practice, and with the CCG, and also spoke to Stuart, and we have written from Stuart to the GP practice as well. This was the same GP practice which we were not able to get through to during our phone exercise. So there is a significant issue there. So I've had latest acknowledgement from the CQC that they are obviously looking at undertaking some action. They haven't said what as of yet in terms of that practice, because we haven't really seen anything like this before in terms of the volume of stuff that came to us in a very short period of time. People all saying the same thing, that they can't get through, they can't get appointments, they can't get their medication. So really, really significant challenges for people in accessing the services that they need. Shall I pause there, Ed? Did you want to ask something?
Yes. Any further comments? Ed, you want to come?
Thank you for that. It sounds like you've been really busy. Just bearing in mind the point previously about the decision-making tool and the weighting on inequalities. So on point 3 of this document, there's a survey you mentioned where you only got 13 responses. And I'm wondering, is that from the Diabetes UK group or the refugee and asylum seekers groups that you've consulted with? And is there any issue with engaging these communities generally? Also on point 4, I'm wondering if there's any outcomes. Yeah. Okay,
so yes, moving down. So yes, the diabetes one is the one that we had 13 responses to. Engagement is a challenge all the time, reaching people, particularly as it's largely digital at the moment. So that there are big chunks of the population you can't reach in that way, but hopefully we'll be going into a period of time where we can do some face-to-face as well. So yes, so we've made links with a Diabetes UK local group, and they had indicated that they thought there was an issue around people's diabetes health checks. So we did a survey which was predominantly aimed at going out through their network. We didn't get a very good response rate back, and actually the majority of the people who responded back kind of indicated there wasn't an issue. So it's an investigatory piece of work to find out whether there is an issue really that might then have led to something else if we had found that. But you know, thankfully, not everything is negative in terms of people's experiences of services. So actually it's perfectly valid, isn't it, if we find that there isn't an issue or people have had positive experiences. So we're not proposing to do any more on that topic at the moment. We could have done more. We could have gone through other routes, but it doesn't seem to be a particularly hot topic. Whereas some of the stuff that I've just been talking about with the GP practices, that was a high priority in terms of my activity and my time in the last 3 weeks, really, when this has all kind of happened. So item 4 is around Healthwatch voice within the new NHS structures and the place structures. So no, regrettably, there isn't progress in terms of having a clearly defined seat or route for Healthwatch Coventry to be involved in Coventry Place. The structures at the integrated care system, the Coventry and Warwickshire level, are still forming. They've just gone out for recruitment advert for the independent chair for the ICS. So it's something that obviously is a priority. It remains a priority. It's important. Our experience is not necessarily the experience of other Healthwatch in terms of how they might be involved in their local areas. It's something that Stuart and I have lots of conversations with people about. Okay, so those are the kind of main aspects of work that we've been focusing on there. So vaccination has remained on the hot topic list, if you want to call it that. So that's both through the volume of individual people that we've been supporting through our information helpline and the broader information service, which encompasses the information that we are really regularly updating on the website, and the amount of visits that we get to the COVID vaccination page on our website, which remain really quite high. Since we last met as a steering group, there has been some progress in terms of the NHS actually putting some information itself out onto the internet. So they now put information on what's called the Happy Healthy Lives Coventry and Warwickshire website, which is a website which kind of evolved out of the old STP. So that there's information on there about drop-in vaccination and stuff. We're still keeping ours up to date and helping individuals. So when we get a new phase of questions where it's unclear how people can get their vaccination, I then escalate that up through the Vaccinating Coventry groups and through other links with the CCGs and other organisations, and hope that I might get some information that might help people eventually. So the latest topic has been around when it was announced that some children had become eligible to vaccination because of their health conditions or them living in households with people with suppressed immune systems. However, there doesn't seem to actually be a route for those children and young people to get a vaccination yet. So we had a flurry of inquiries from people saying, oh, we've tried, we've been to 119, we've tried to talk to the GP, everybody says no, basically. So often there is a lag between the announcements and the actual process being put in. So it has then more recently been announced that now all 16 and 17-year-olds can get the vaccination, but at least they've sort of said this time that it's going to start in a few weeks, because the guidance has only just come to the vaccination centres to enable them to think about how they're going to organise it. So vaccination will continue to be a topic, I'm sure. We will also be entering a period shortly where there'll be further consideration around a booster dose potentially and how that will be organised. And then we've also got the flu vaccination season as well. So you have some figures in the report around the use of our information helpline and our social media channels and our website. What we've also started to put in place, we're doing this in a phased way, is we're collecting more monitoring data from people. So this is good practice and something that we want to do. So people who contact our information helpline, we have a web form which we put up, which we started using sort of in earnest at the start of the COVID pandemic last year, and actually it's really well used by people. People seem to like putting their question in a web form and sending it to us, and it's because it's a form. We can require people to fill out certain fields. So we've added ethnic monitoring information into it, and gender and age. And then we're going to be working on how we collect that information from the people who contact our information helpline through the other routes. So people ring us. So let's think through what reasonably you can ask people in a phone conversation before you start having a really long phone conversation where you're trying to get lots of information about them. And then we get people who just email us. And in some ways, those are the hardest to deal with, because often people don't even give you sufficient information to be able to answer their question in the email, so they certainly don't include information about themselves. But we're probably going to be putting in place a kind of follow-up survey for people and seeing how we can collect some more information in that way. So also on there, you've got the people element. So in terms of us going out to recruit some new micro volunteering roles, and the update on the staffing situation, which unfortunately is still not resolved within the team in terms of having all posts filled, people inducted and working in them. But it will be great. Hopefully on Monday we have somebody starting who is the lead post for the information helpline and the information service. So at the moment we've kind of been, well, Owen's been largely doing that, but when he was off on leave, we had to cover that from other people in the staff team. So and it's one of those things, you don't know how many inquiries you're going to get on any given day. So so that's the work that we've been doing. Any other questions?
Ed's made an observation about keeping in touch with refugees. Just want to just articulate that, Ed. I know you put it on the chats function.
Yeah, I just thought it's worthwhile we continue trying to get the responses and reach out to asylum seekers and refugees, because when we were part of the EU, Coventry was one of the leading cities in the UK, offering these groups safe places to live. Sometimes their concerns probably won't be captured, in the press. And there's plenty of local organisations that we might engage with, especially if physically consulting people in person might be possible in the future.
Indeed, Christine, you were just indicating your support for that, were you?
Yeah, well, very quickly, I absolutely agree with that. And I think when we look longer term at the steering group membership, perhaps we want to try and encourage Coventry Refugee and Migrant Centre to have a representative to be formally part of the steering group, because obviously I think the issue of underrepresented groups come up time and time again. And obviously those of us working in the voluntary sector, we are doing the work, we're working with communities, but I think having somebody around the table who is the largest representative of a particular group in the city, I think would be very useful.
Yeah.
That was it.
So the group that Felicity met with, we did that with, it was a smaller group actually that is supporting refugees, not the more established one, and actually it was really insightful to hear people's different perspectives, and they are different perspectives which I think aren't understood sometimes. So that there was a conversation about COVID vaccination, as you can imagine, that was part of that. And when I go to the kind of vaccination planning meetings from the kind of NHS perspective, I don't think the sort of perceptions or the take on it that refugees might really have is kind of understood or factored in, as to why people might not come forward, and how it's kind of all sort of intertwined with a whole host of other stuff really, in terms of people's experiences of living in Coventry. It sometimes feels like the perception is that they've just been difficult or whatever, but actually people have really complicated and challenging lives, don't they? So yes.
Good, thank you very much. We move on. Ed indeed touched on this, I think, in the last comment he made about refugees and asylum seekers, about returning to face-to-face activity, and there's some guidance on that, Ruth, please.
Yes, so Healthwatch England, in their role of supporting Healthwatch England and providing guidance, have come out with updated guidance, which is around return to face-to-face working, and there was also a workshop held for chief officers as well by Healthwatch England. Because it's one of those topics where I guess you've got a spectrum of perspectives, haven't you? And sometimes a spectrum of concerns and things that you need to consider. I consider the guidance and some templates for risk assessment, which Healthwatch England have provided, to be really quite useful. So we are going to be using them. So we were due to be doing our first outreach activity. We were going to be going to a community event last Saturday, and Felicity was pulling that together, but then unfortunately Felicity had a health emergency and she's got to have an operation, so we had to pull out of that event. But we did work through the kind of process of assessing how we would approach things, and what we needed to consider in terms of how we keep people safe, and what we put in place. So the other factor, which is something that we need to work through, is that from the 11th of November, I believe it is, Healthwatch volunteers who do any visiting to care homes will need to be double vaccinated, as anybody who goes to a care home in a professional capacity falls under the legislation which has been taken forward about vaccination in care homes. So that's something that we've got to feed into our processes. I don't know as of yet when we might consider doing some interim review activity. I imagine there'll be quite a few challenges around doing that. And we would also obviously have to have defined a piece of work where interim review was part of it, because interim review isn't work in itself, it's a method. And I gave a presentation to the senior management team of Coventry City Council, and I was asked about interim review. So we would also probably be looking for support from the council to, if we were going to social care facilities, for example, to help facilitate that. But there's going to be lots of different things that we need to consider in terms of how we plan things, and the decision, and it sort of feeds into decision making as well, really, in terms of what and how. But we'll be looking at coming up with a community engagement plan which involves both the digital and the face-to-face for the kind of next phase, and we're phasing back into return to the office at the moment for office-based working, although for some of us, like me, a lot of my interactions with the strategic people will remain online, and actually it's easier to do that on my internet connection at home. So there are challenges where you're trying to do a blended approach, really, because some of this tech is kind of, it's like you're either all in or you're not, really. But as yet, I don't think we've been invited to any face-to-face versions of our external meetings. So there hasn't been a face-to-face health and wellbeing board or a scrutiny board. So obviously the Director of Public Health is kind of heavily involved in those meetings, so may have a view but at some point. So it has been flagged to me also about what we should consider in terms of these steering group meetings, and whether we should when we should plan to have one in a face-to-face setting. And I kind of say that it's kind of up to you as members, and want to put people on the spot in this meeting, but maybe if we send something round so that we can say the extent to which you might feel comfortable doing that, because I don't want to put a steering group meeting on and there not be anybody there. That wouldn't work very well, would it? So our meeting after this isn't until the beginning of October, is it? So that the other consideration is have the meeting venues opened up. Hopefully some of them have. Some organisations have also sadly closed. So the St Peter's Centre in Hillfields has closed as a result of the financial impact of the pandemic, and that was a good space in a deprived area, which a lot of organisations use, and some organisations were based there as well.
Yes, it'll be quite a change, won't it? Meeting people and indeed, you know, changing our wardrobe instead of sitting here in pajamas and shorts. We have to get dressed properly every day. Dennis, you want to make an observation?
Yeah, just linking a few things that have been said already together. I think the time is now optimum to ensure a lot of our efforts are involved in getting the CCG to get the GPs to revert back to face-to-face and more inclusion, or at least to get some metrics on what's going on. You know, I've mentioned the fact is they do offer this telephone contact, but you can see from our report it's pretty abysmal. People have to get up 8 o'clock in the morning, and if they're ill, they have to wait an hour, and then they don't get through, and then they blah, 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 blah. Now, and the CCG seem to be happy with them just providing a route, but don't really monitor that route to see what metrics like calls abandoned, time to get in, how many appointments are there being offered, how many referrals are made. There's no monitoring of this whole new procedure, which normally I would say, all right, put it down to pandemic, let's go out of it. But I think they're going to try to maintain this. And so I think it's an opportune time for us to put pressure on the CCG to ensure that the service provided has some metrics associated with it, so we can see if it's any good or not, because we only get anecdotal evidence at the moment at best. And now
If it's any reassurance for you, Dennis, at the last several meetings of the CCG and other bodies that I've been in attendance with, they're getting sick of me asking them to properly evaluate the use of telephone triage, video consultation, and the use of digital generally in dealing with patients rather than face-to-face. Now, the last meeting, which I think actually, yes, it was a CCG AGM when I raised this, I was assured by the chair, Dr. Raystrick, that they were going to go, though they are conducting an evaluation. This is what I was told. They hopefully, and I said, when will the results of that be available? I was told probably the autumn. And then she said, we are happy to work with HealthWatch. And she says, I've discussed this with Ruth before as well. We're happy to share with HealthWatch the outcomes of that and working together to try and address the very issues, Dennis, that you've been raising. So we have been knocking at the door, bashing at the door about this.
Yeah.
But I think we have, with respect to it, I mean, they do have a big vested interest, the CCG.
Yes, they do. Yes.
And the problem is that we don't record anywhere, or we don't have a public platform to record that such and such performance has not been met, you know, or any, because we don't have any guidelines about what they're trying to achieve. All we get is
just a couple of things, Dennis. So there are national directives still in place around how GPs do things at the moment. So there are some things which the CCG would say aren't in their gift. So this total triage model, the phone model, that's on a national directive. So just remember as well that HealthWatch England has done work at a national level, and they're calling and working and lobbying at a national level for a sort of inquiry into access to GP services. So there's always work going on, but in terms of collecting data and stuff, I mean, we just have to be a little bit cautious and kind of realistic in terms of what reasonably a CCG is going to have from independent GP practices. There is some national experimental data which is being produced by
we've lost your microphone again, Ruth. Ruth, we've lost your mic. You're muted again. There we are.
From the national body that pulls the data together. So they're trying to see how they even track the types of appointment and stuff. So if things aren't being recorded in a particular way, then data isn't going to come out the other end, is it? So one of the points that I made at scrutiny board when they were focusing on access to GP appointments, and the councillors were quite vocal, representing their constituents' experiences in terms of access to GP appointments. But one of the points that I kind of raised was, well, what is an appointment at the moment, for example? It's because to a certain extent, you're being triaged when you phone the GP practice, aren't you? So.
But my point's a bit more elementary than that, because nobody these days puts a telephone system in that doesn't have data associated with it, which has those metrics, you know, already. Now, I can't understand why that the CCG doesn't set as part of its monitoring of the service. So send us those metrics every month or whatever. Of course, it's the same with Pod. We don't get any metrics on that either, you know.
Well, it's not published, but yeah, they will have data on Pod.
But anyway,
I think it's also about, you have to bear in mind what's in the GP contract in terms of what GPs have to do and what they don't have to do, and how that impacts flow of information as well. So I think we're all on the same page in terms of what we're picking up from the public in terms of their experiences is really valid, and it varies actually around Coventry, as it did before these systems were put in place in terms of how accessible GP services are for different people in the population. The real concern is when the practices flag up where there seem to be the significant issues when they're in the deprived areas where people are already experiencing more barriers and health issues and lower life expectancy and a load of other stuff, isn't it? So yeah, so we'll keep being on the case.
We will indeed. There is another issue just to bear in mind, just as an aside, that the data, as you say, Dennis, is probably available within the telephone systems. However, very often, in fact, almost entirely, I think is the case, GP practices put their telephone systems out to a different contractor. And it's a question of who actually owns the data, and then can you access that depending who does own the data. So there are not the case.
Hopefully, like all NHS systems, they have been validated against some kind of conformance testing and all this lot. So it won't be, they won't be able to get any cowboys to do it. It would have been anyway. But I've rest my case. I mean,
indeed, you would hope that's the case, but I can tell you that not all the systems are working as they should, or haven't always been working as they should. But thank you for that. We are singing from the same hymn sheet. Can I just say we are slipping a bit behind on time, so if we can just
okay. So I just have one final thing to mention, which isn't specifically on the agenda, but I've had an approach from Coventry and Warwickshire Partnership Trust, CWPT, who are refreshing their vision, mission and values, and have asked for the input of Healthwatch Warwickshire and Healthwatch Coventry. So is that something that any of you would volunteer to do via a session with Coventry and Warwickshire Partnership Trust or not?
They do have a new chief executive there, and they're very keen to move forward on this. So is there anybody that would be interested in being involved with that? Please indicate.
Ed? Yeah. So we need a
Christine
few.
with a thumbs up.
Christine. Catherine.
Thank you. That's very helpful. Thank you very much.
Okay. All right. So I will go back to them and see. We'll organise it as a separate meeting.
If anybody else feels they'd like to come forward, then please let Ruth know if you would. Thank you. If we can bear in mind the time is slipping a little bit, let's move on then to the reports that have been circulated via paper 4 from the various meetings and groups that we've been attending. Anything that anybody from what you've read you wish to highlight from those reports? They have all been circulated, I think.
I think you can see that there's themes, aren't there, between them in terms of some of the topics that are being covered, which is always the case. The
one worrying thing that I would just highlight from some of the meetings that I attended, both the CCG meeting and indeed some of the meetings organised under the various banners where the City Council's been involved, is the concerns, obviously, about the vaccine take-up in certain parts of Coventry. And at the time these reports are written, they're all talking positively and optimistically about moving forward and making progress. Yet we've seen the reports in the local media in the past week that Coventry is actually the worst performing part of the country at the moment for vaccine take-up, which is a worrying trend and obviously something we just need to keep monitoring, I think. Ed, yes, please.
Yeah, I was very interested, but David isn't here to comment on his report about the Health and Wellbeing Board and this presentation that was given by a digital mental health platform for children and young people called Kooth, which isn't something I've heard of before. But looking at it, it seems to have been rolled out almost across every CCG in the country very rapidly. And I'm wondering how that's happened, how that service has been evaluated. It says it puts children and young people in contact with experts, but I'm wondering whether it's actually an algorithm or just, a validated questionnaire. It's like the problem we have with 111, who is actually operating the system. They're completely inscrutable, and the companies don't release the doctors that are working for them. So it's just something to be on our radar, I think.
Yeah, good questions. We have got some information about Kooth on the Healthwatch Coventry website. So you might be able to link off that and go to have a look at it. It's a direction of travel around having more support services which are kind of online and sort of go through them yourself, support services, and there's other streams of work for other groups of people around mental health, which are in train locally as well, really. So for some people, it could be the thing that's find very helpful. But yeah, valid questions.
Thank you. Any other comments from the reports that have been circulated to you from meetings that members have attended? No, nothing forward. And we have noted your comment, by the way, Ed, about data collection. Thank you. It's on the chat. If anybody wants to look at that, thank you very much for that. The Coventry and Warwickshire Respiratory Steering Group, Ruth.
I just wanted to flag up that I had a communication inviting Healthwatch to join the Coventry and Warwickshire Respiratory Steering Group. So as is sometimes the case with these groups, it's not easy to see if that would be a useful use of your time until you actually go along. So I went along to a meeting, and at the moment I'm not sure, I guess, in terms of if that is the best use of time in terms of being able to contribute around respiratory services. So there's a sort of service improvement agenda around respiratory services across Coventry and Warwickshire. And so this is a kind of reinvigoration of a group which I think has existed previously around how to overcome some of the pathway issues and barriers and ingrained ways of kind of working, and how to refocus services. So potentially of interest to us, because actually looking at patient pathways and journeys through services and how people access support at various times is a good thing to do from a Healthwatch point of view. So I'll keep you posted on that. It may be that just going a couple of times kind of flags us up to them, and maybe they'll kind of have conversations with us at relevant points in time. It doesn't seem like they're at a point where they are planning to talk to patients or service users as yet. There's a few other things to be addressed first.
Thank you very much. No further comments on that, I don't think, I can see. Thank you very much indeed. We move on then to various items for information. First, regarding the people involved with developing the ICS route.
Yeah, so just to bring you up to speed then, so Phil Johns, the relatively new accountable officer of the merged clinical commissioning groups, has now taken the role of the lead officer. I'm not entirely sure of the job title. I'll have to find that out, for the integrated care system. So that means that Andy Hardy, the chief executive of UHCW, who had the kind of lead role against of the health and care partnership, has stepped away from that role, and recruitment has opened for the independent chair role for the integrated care system. So Professor Sir Chris Ham, who has been the chair of the Coventry and Warwickshire Health and Care Partnership, is not continuing in a role. So that's the kind of update. So I can send the adverts around. I keep getting sent the advert multiple times a day for the chair roles. Do you want me to go on to other updates, Stuart? So,
Yes, please, if you would, yeah.
Yeah, so you've got a link there for information. It's a national thing, but of course we'll have a local impact. So NHS England is proposing new mental health access standards. So it's worth having a look at those. So it includes standards, for example, I'm kind of quoting here. So for an urgent referral for a community-based mental health crisis service, a patient should be seen within 24 hours from referral, for example, and other proposed standards around access to mental health services. Mental health services are extremely busy at the moment. That's something that's sort of loud and clear from our communications and meetings with the Coventry and Warwickshire Partnership Trust, and they are services where there seem to be significant staff vacancies as well, not just here, but all around the country in terms of the workforce strategy for mental health services is perhaps a bit lacking at a national level. So I draw that to your attention. And the final thing is a good communication with patients waiting for care guidance from NHS England. So this is something that has been flagged up to us variously. So people are on waiting lists for various services, not hearing anything, not knowing if they're still on the waiting list, thinking they might have dropped off the waiting list, not knowing if they should call somebody, contact somebody or not. And there's been the beginnings of a conversation locally around whether more should be done. And I have offered input should that be helpful as well, because it's really important to keep people in the loop, isn't it? So
Indeed, I just love that line, good communication with patients waiting for care. That surely is fundamental to the whole principles of the NHS. However, thank you, Ruth. Health Watch England work, let's move on to that then, shall we?
Okay, so I've included a link to the latest update on the Health Watch England website, which is about patient data. So this is the issue that there was earlier in the year about data sharing for public health purposes from GP records, which was announced, well, it wasn't really announced, nobody knew about it, and the deadline was very close for the data sharing to take place. Well, the deadline's been extended, and there's now more work going on into communication with people, so that people actually understand a bit better about what this is all about and can therefore make informed decisions about whether to opt out. So you're presumed to have opted in unless you've opted out, is the process, but unless people have some information, they're not informed. So that's useful. There's also some information in that in terms of some examples of what the data is actually used for, and I guess some of the important examples in terms of how that data sharing facilitates some NHS processes. So who might be called for particular screening, for example. So it's worth having a look at. And then I've pulled together a quick paper which is based on Health Watch England information, which is a kind of update on hospital discharge and the discharge to assess model. So a nationally determined discharge to assess model was put in place in the first wave of COVID with a view to speeding up hospital discharge to ensure that beds were available for those who needed them in hospital, and this continues. But Health Watch England did some work on this a while ago, tapping into work from the broader Health Watch network around some of the issues with this. So there's been updated hospital discharge guidance, which has picked out key points which were raised through Health Watch to try and make the process and experience better for the patients and no doubt their families as well. So that's for your information.
Is there any further news about the more about the good practice being used more widely, Ruth, on that? Because one of the points it makes is that it's patchy, not everybody's exercising good practice.
Yeah. So, I mean, I had some conversations last year around potentially doing a piece of work locally, working with some of the organisations involved in hospital discharge to see if we could look at this. It didn't come to anything at the time. So it's something that I'm kind of keeping in my mind, really, to see if there's an opportunity to see how this is being implemented and what it actually means really for people as well, because there still needs to be, and then Health Watch is the ideal conduit for this, isn't there? If what's decided nationally is not working for people locally, then there needs to be a way of raising that back up to the national decision-making structures, and that's what's happened already through this Health Watch England piece of work. So,
Dennis.
find the mute button. Yeah, reading this discharge and in light of the previous paper, which strengthened that patients should be involved in this shared decision-making thing, which I thought was very, very good, and we ought to try and push that. But coming back to the discharge, having been through this recently, I come back to this fact that they keep making decisions forward, like they send you out, but they never confirm that the actual plan or whatever has been met. You know, they don't, there's no confirmation going back, because nobody's seems to be in overall control of the process. You are handed over, and the people who you handed over to, like the local GP, don't know really, and they don't really, there's no real, who is monitoring that the patient has continuity of care and the things in the plans are actually carried out. Because I mean, I contacted my GP because I haven't heard from them after about 4 months, when the discharge thing said this should be reviewed in 4 weeks and certain things should be done, you know. And I could see him just reading the notes as I was talking to him, and you know, catching up. Now that a lot of people are going to get caught out this way and suffer. There ought to be these open loop systems that the NHS seem to operate lead to very big problems. There ought to be some way of closing the loop back and saying, yes, it's been carried out, no problem, and it's ongoing, whoever you are, you know. So that's where this discharge paper needs to be updated to say that let's have some kind of feedback loops to say that the plan has been actually carried out. That's my main
dining room.
Yep. Thank you. I think we've lost Ruth just momentarily, so we'll give her a chance. Ah, so there she comes back again, I think. Yes, there she is. We lost you for a moment, Ruth. Did you hear what Dennis was saying?
No, sorry, I was just kicked off. My my internet provider had an outage there for a bit, so fill me in. So,
well, Dennis was concerned that I mean, don't let me put words in your mouth, Dennis, about the discharge paper perhaps not being as up to date as it might be. Is that correct?
Yeah. My main point, Ruth, was that there's no feedback loops at the points in the plan to say this bit's been carried out, with the plan is progressing. You know, it's very much like the 5-year plan and the 10-year plan. Nobody really confirmed that anything is really being done, and that's why we get so frustrated, I think, you know. But it's more of concern when you're talking about patients' health. If they go, the discharge plan is made, there should be elements in it to confirm that stages have been met positively. Positive feedback is what we look
Just before Ruth replies to that, Christine, thank you, got your message. Thank you very much indeed, and thank you for attending. Thank you. Ruth,
I agree. I think that the challenge at the moment is that there's no one organisation responsible for you when you're being discharged from hospital, and some people would be what would be called the simple discharges, and some people are on different care packages and things, aren't they? So
sorry, Dan.
It's often presumed that your kind of GP is the catch-all, but then they might not be in the loop. So, so you say yes, that there's definitely more that should be in place. Stuart, you're on mute.
Thank you. Yes, if we move on then to the next item, which refers to, as we touched on earlier, there's going to be a change in leadership. There is a change in leadership happening in Healthwatch England. Yes,
so Imelda, who's the Chief Executive of Healthwatch England, is stepping down, and Sir Robert Francis QC, who is the chair, has been confirmed as chair for a further 3 years. So both some continuity and some change there. Imelda's been working very hard at a national level, liaising with ministers and senior officials in the NHS and social care on behalf of people, essentially. So we wish her well and I think she's sort of retiring, I think is the intention, and we'll wait to see who takes it on next.
Indeed, sir. Any other points anyone wants to raise on that item? No, thank you. In which case, you've been sent or issued with various items that you may find of interest that you might want to spend some time reading. Anything you want to draw out from that, Ruth, that particularly to draw our attention to?
No, it's a selection of various publications that we've been made aware of since the last steering group, not all of them, obviously. So trying to cover some different topic areas, really, for your consideration and just information. So some of it is there's some interesting stuff there about people with multiple conditions. And the impact of one group of patients who are waiting for surgery, which is obviously clearly a situation that many people find themselves in at the moment, isn't it? So,
indeed, thank you. Any other business? Having said we were behind time earlier, we've really caught up considerably now. I think one thing we do need to keep an eye on in various guises, in various ways that we perhaps touched on, is the role of young people in this city, and I talk about children as well as the older young age group, if you see what I mean. There's the vaccination issue for those of now 16 and above, and making sure the vaccination take-up is pursued in the appropriate way. There's also, I think, something that we've touched on briefly, the children and young people being referred for assessment for a number of various issues, eating disorders and mental health issues and the like. So there's a number of things there that I think we just need to keep an eye on, really, through the various organisations with which we partner and the work that we do.
yeah, absolutely.
Any thoughts anyone wants to offer on any other item on that or any other business? In which case, thank you all very much indeed for your attendance. Whether we meet again face to face, properly dressed, or whether we come back to this whole issue of a multi-screen melange of happy smiling faces, we wait to decide. But our next meeting will be on the 12th of October. So thank you all very much indeed.
Well, I'll be in touch with people about people's preferences. Obviously, we will need to follow whatever the advice is at any given moment in time as well. So,
right at the end of the meeting, we can see the happy smiling face of Sue Ogle. There we are. Look at that. Never too late. Never too late. So, thank you. Thank you very much indeed, everybody.
Thank you, everybody.
Thank you. Bye-bye.